Tonight. My name is Jess, as Amy said. I am a social worker with the Transgender Health Program, and part of my time is spent with our pediatric gender clinic. And so I'll be drawing on that experience today, and I use they, them pronouns. So our talk today is about supporting and affirming gender diverse youth. And we often say in our clinic that what we do is more than medicine, which means we understand that hormone therapy, pubertal suppression, and surgical care can really be life-changing and really make a big difference in the lives of our gender diverse youth, but it's really just one piece of the puzzle, and that youth are existing in a vacuum, and so we need to take those other factors into consideration. So we'll be talking a little bit about that tonight, and I've left plenty of time at the end for questions, so please send them in along the way. I guess my clicker doesn't work when I'm in this. There we go. So just to start off and do some level setting with the knowledge of where you all are coming from, I just want to touch on gender identity just a bit. So when we talk about gender identity, it's our own internal sense of self. It is different than sexual orientation, and it's different than gender expression. Our own internal sense of self sometimes aligns with the gender role that we were assigned at or before birth. In that case, we're talking about folks who identify as cisgender. For folks who find that their gender identity does not align in some way with the sex or gender role that they were assigned at or before birth, that's when we start talking about folks who identify as transgender, gender diverse, whatever terminology they are using for themselves. By age 2 or 3, we know that youth become aware of physical differences in bodies. By age 3 or 4, folks are labeling themselves as boys and girls and really kind of separating the world into categories in general. And by age 5, our gender identity is internally consistent. What that means is that folks understand who they are, potentially as early as 3, 4, 5 years old. However, that is not everyone's story. And it also depends on those external factors in a young person's life in terms of whether they're able to explore their gender identity and express it in a safe environment. Some of the most powerful language that I hear from young patients, young people that I work with, comes in this age 3, 4, 5 range, where people will say things like, I am a girl, I am a boy, I'm going to grow up to be a woman, I'm going to grow up to be a man, God made a mistake, I have the wrong body parts, things like that. And generally speaking, when we hear kids coming out at this age, it tends to be in a more binary fashion. That's just the way that kids' brains work, very concrete and black and white. So it might be possible that there's a 4-year-old who says, I am a boy, and then as they continue to age and become aware of other gender identities and experiences, may recognize that they actually are gender fluid or binary, and are just acquiring more language for that. And then gender identity is who we are internally. Sexual attraction, sexual orientation is who we are attracted to, with, etc. And as you can see here, that develops much later in life. Interestingly, what we often hear is that youth are able, and you may have experienced this in your own families or in your own work, youth are able to access language around sexual orientation more readily or easily than they are around gender identity. So it's very common for us to hear, oh, my child came out as gay when they were 11, and now they're saying they're trans, kind of what's up with that? And both experiences are valid, and that child may be gay still, but may have a gender identity that is different than what they were assigned at birth. The other thing to remember is that everyone on this call has a gender identity. Everyone on this call has a gender expression. And no two people are going to experience their gender the same way as someone else. So even if the person who is in the room next to you or who you recognize on the screen uses the same term for their identity, how that feels to that person is not necessarily going to be the same as what you experience your gender as. And I often say that trans folks, gender diverse folks have to think about gender identity pretty constantly throughout the day. And so for cisgender folks who are on this call, it's important to start thinking about how gender shows up in your life so that you have a relationship with gender identity and expression and can kind of meet on that playing field, so to speak, even though the experience can be quite different. So when we think about gender dysphoria, which is the official diagnosis that someone would carry if they were seeking medical care, we generally prefer the term gender incongruence. It speaks more to kind of that disconnect between what someone was assigned at birth and how they experience themselves. It is a typical experience in early childhood for all kids to engage in sort of imaginative play that may be gender nonconforming or gender variant or whatever terminology you want to use. And just because it's showing up in early childhood doesn't necessarily mean it's going to continue into the teenage years and into adulthood. So we tend to think of this idea of insistence, persistence, and consistency when it comes to someone's identity over time. That doesn't mean that their understanding doesn't shift or that the language that they're using doesn't shift, but what it means is the experience of gender incongruence or distress around their gender or gender dysphoria persists kind of through all stages and until they feel affirmed. And so when we think about this experience of gender dysphoria, about 40% of kids who experience this gender incongruence early in childhood will continue to experience that into their teen years and into adulthood. You may have also heard in the literature or in kind of pop culture this idea of desistance, so someone who does not continue to experience gender incongruence following puberty. And then obviously, I think the fear that is on a lot of folks' minds is this ability to have a crystal ball. So how will I know that my child is going to persist in their identity? What if they change their mind? What if they detransition? And what we know from the numbers is that only about 1% to 2% of trans folks stop living in their previously stated identity after following some sort of medical intervention. However, it is rarely related to a complete shift in gender dysphoria or in gender identity and a return to their sex assigned at birth, as much as it is related to loss of community, of family, and the pain and the grief that goes along with that is just too much to withstand. And there is, as I mentioned earlier, a group of folks who may access language around being a trans man, a trans woman, a man, a woman, and then recognize that they experience themselves as more non-binary or agender, gender fluid. And so some of the medical interventions that they previously sought out don't necessarily align with their current experience. So that's just something to keep in mind. When we see that gender incongruence is persisting into puberty, this is generally a strong indicator that medical interventions are needed and that they will result in positive experiences. And between ages 10 and 13, this is a critical time where folks are watching their peer group go through puberty. They've learned potentially in health class that their body is about to change, and we tend to see another emergence of distress and discomfort around this age range. So now that we kind of have a general understanding of gender identity, how it develops, and how we kind of think about gender diverse folks aging through the different developmental stages, I want to talk a little bit about what we understand about risk and resilience as it relates to gender diverse youth. And we often get the question of how many folks are we actually talking about? It seems like a trend. What do we know from the research? And most of our data gathering methods are pretty incomplete and in some cases inaccurate. But you can see here from the Oregon Healthy Teens survey that was completed in 2017, when folks were surveyed in 8th grade and then again in 11th grade, there was about a percentage jump in the folks who identify as transgender, non-binary, gender conforming, non-conforming, or gender diverse in some way. And so roughly it was about 27,000 students in 8th and 11th grade in Oregon. So last summer we participated in a grant from the Oregon Health Authority to take a look at outcomes and needs assessments for transgender and gender diverse youth. And this took place with a 27-question anonymous online survey. We also held 2 focus groups in Eugene and Coos Bay, and then did 4 individual interviews where we were really trying to take a look at not just the Portland experience, but the statewide experience. And you can kind of see the breakdown here between what folks self-identified as their geographic location, and that most of our respondents to the survey were between 16 and 19. What came out of this is that folks are feeling like they don't have access to a medical provider to support a medical transition, and that roughly about 60% of folks identified that it was anything from really difficult to sort of neutral in terms of accessing specialty care to affirm their gender identity. And this access to care is impacted by those other factors that exist in youth's lives. So feeling like their doctors needed more education, feeling like they had to travel great distances to find a provider that would understand what they needed, not really understanding insurance or being concerned about the cost, and then family support or family disagreement as being one of the barriers. We also asked an open-ended question of what do you fear most? And I will say that everyone on our team was not necessarily surprised, but this statistic was very impactful. And every time I talk about it, frankly, I still get choked up. But nearly a third of the folks who responded to the survey said that their biggest fear is physical violence or being killed because of their identity. So when I hear people say that it's a trend, this is a statistic I often point to, that if this is truly a trend, why are so many people sort of persisting in trying to be affirmed in their identity when there is such a threat or a perceived threat for violence or death? And what can we do as adults to start making the world a little bit safer, or feel a little bit safer for our gender diverse youth? And we'll talk a little bit about that as well. And then the other striking thing was the feeling that they might be alone or rejected by their families, by their communities. And about 40% of the respondents said that they felt like their family rarely or never understood or embraced their gender identity. We also asked what folks enjoy most about life. Not surprisingly, friends was a big category there, and pets also can be very protective. We see that come up in clinic a lot, where patients will say, you know, I don't feel like I can talk to any of my people, but I can talk to my cat, and my cat is the thing that's keeping me alive right now, or that motivates me to attend school. So when we ask about chosen family, we're including animal family members in that too. And what we ultimately found from this Oregon Health Authority grant is that there's a large need for training in schools with mental health professionals and with medical professionals, that we really need to kind of find the golden ticket to what helps families feel supported so that they can support their youth, to prevent youth rejection and to improve outcomes. And that we really need to work on access to insurance and education to families and patients about what that insurance coverage looks like so that they understand what they have access to. And then accessibility across the board to affirming mental health providers, so that we can start impacting the high statistics around depression, anxiety, and suicidality. So as I said earlier, we often talk about what we do as more than medicine. And this is just a sample of the different stakeholders or influences that may impact a single youth's life. So they're interacting with their caregivers, with their school. There may be DHS or Oregon Youth Authority involvement. They may have a community. The media is huge. The level of distress that folks are experiencing in this current political climate is quite high because they're signing on to social media and seeing that the president has rolled back something around their health care, or that another trans person has been murdered. And whether they're talking about it or not, these youth are carrying those experiences around with them. And so as adults in their lives, thinking about how we bridge that gap and how we invite that conversation, even if it feels like a scary conversation to have, is something important for us to consider. And what we know from the research is that, and this might be common sense, but when kids are supported in their identity, they do better. So family support is a protective factor that can reduce the experiences of gender diverse youth around anxiety and depression to that of their cisgender peers. And when kids are affirmed early and affirmed in all contexts of their lives, so school, home, faith, community, etc., this study in particular showed that there was no elevation in depression and only slightly elevated levels of anxiety, but they didn't reach clinical range. So when we talk about supporting families to support their youth, it really can be a life-saving intervention as we kind of go forward. And that brings us to this idea of supporting a social transition. So when someone identifies a chosen name or pronoun, and that's used in multiple contexts, we see that suicidal ideation drops by about 30% and suicidal behavior drops by 56%. And when we consider that suicide attempt rates are upwards of 60 to 70%, depending on the study or survey that you read, this is a small change in behavior on the adult side that can result in a life-saving intervention. And as caregivers, as school personnel, whatever your role is, start thinking about how to have these conversations, how to hold people accountable, and also checking in with the young person themselves around how they want you to show up as an advocate or ally. Do they want you to be the super ally that corrects everyone in their path that misgenders them, or do they want you to be someone who selectively has one-on-one conversations with important stakeholders, and that might change on a day-to-day basis, but it's an ongoing conversation to have. And when we think about health, it's not just hormones. Health is really a holistic picture, thinking about all the different touch points that someone has in their life. So how do we make a school environment healthier for gender diverse youth? How do we connect them to peer groups so they don't feel as isolated or alone? Who are their friends? Do they have access to in-person connection, even in the time of COVID? Or is it all online? And then when we start talking about faith communities, how do we help someone who has a strong faith belief maintain connection with their community or their belief system, even if historically that faith community hasn't exactly embraced gender diverse folks. And then mental health support, thinking about someone's strengths, and then sometimes siblings and extended family get left out of the picture here, but those folks are just as important for providing support, or can be just as damaging if there is a lack of support. And as we think about holistic care and health, and what we need to think about and consider when we're providing family-centered care, or when you are thinking about your family and how you're interacting with the outside world, we really encourage an intersectional lens. So recognizing that gender identity is only one piece of the pie here, and that someone's race and ethnicity can impact their experience of gender and experience of trying to express that gender to the outside world. Religion, age, when we're talking about youth, there's a lot of ageist beliefs, right? Like that the adolescent brain is impulsive, and that this person should wait till they're 18 to come out or pursue a medical intervention. But I often ask the question of what's the difference between 17 years old, 364 days, and that magic 18th birthday. Nothing magical happens in someone's brain. It's just a matter of, who feels like they can sort of pass off the responsibility, so to speak, or not live with the weight and the fear of making a decision on behalf of someone else. But we also want to think about, as someone is expressing their gender, what role models they have, and particularly if they are from a faith community that doesn't have a lot of positive trans role models, or all they see in the media is representation of white transgender people. How does a young person of color who is exploring their gender identity access role models and language and experiences of folks who are more like them? And then how do we think about geographic differences across the state and the language that people might be using, their ability to come out and disclose to people versus having to wait or be strategic. And then thinking about what youth as its own culture means, and how that interacts with the other generations in a family, in a school system, etc. So I've mentioned mental health a little bit here, and frankly, from our standpoint, anyone can benefit from mental health support, including ourselves, especially in these unprecedented times. And the reality is that there are insurance requirements for there to be a role for mental health providers in the context of a medical transition. But we really see a therapist as a partner in care that can help someone explore their goals related to transition, prepare for next steps, and then address sort of the experience of seeking affirmation and medical interventions and feeling finally solid in one's own skin, but then not having the rest of society kind of mirror that back. I often say that one of the significant changes from this idea of gender identity disorder to gender dysphoria as a diagnosis is that gender identity disorder sort of located the problem, so to speak, within the individual. Gender dysphoria speaks to the experience of, the individual is okay with themselves, but it's the rest of society that is causing distress for them in some cases. And so how do we think, depending on what our role is in a young person's life, how do we think about starting to make some changes in their immediate world and then in the larger cultural context so that this becomes less of an issue? And when we think about caregiver and family support roles, it's not just paying or covering someone under insurance. It's transportation to and from appointments. It's being able to communicate to those insurance companies about medications and procedures and what the cost share might be. Housing, obviously, advocacy with the extended family, potentially administering injections or other medications, and then a post-operative caregiver. And if someone doesn't have access to family, whether it's chosen or otherwise, then they're potentially having to cobble these very important roles together, and can be in sort of a house of cards situation, where if one element of this is removed, then the whole house might come crashing down. And so that brings us to this idea of advocacy and where we can start thinking about change. And so within schools, there are really fabulous organizations already working alongside of or within schools. There are often champions within different school departments or individual schools themselves. So I always encourage building a relationship with the school counselor. They can often be a great ally and advocate for a young person. And you also want to find out what the anti-bullying policies look like, what the support is for social transition, and how in alignment a particular school or school district is with what the state of Oregon indicates, which is that kids should be able to attend school under their affirmed name and with their affirmed pronoun, regardless if there has been a legal name change or not. With faith communities, there are bodies of research and information out there that really demonstrate support for gender diverse folks and draw upon that faith community's belief system to sort of advocate for why it's the right thing to do to support gender diverse youth. And we do have some resources around that. And sometimes it's a matter of cultural translation and thinking about where is the common ground between a family's belief system or a community's belief system and what it would mean to support a youth in their identity. And then we think about siblings and extended family. There are some support groups that are out there, for instance, through PFLAG, and we want to think about strategies for having conversations and setting boundaries with family members. And sometimes that's as firm as, my kid is using this name and this pronoun. If you cannot respect that, we cannot continue this relationship. Or something a little softer. We understand that this might be new for you. Here's some reading material. We're happy to discuss it outside of Joey's presence. Or maybe Joey wants to be the one to educate their own family members. And so we want to support that and also recognize that that can be a big lift, a big burden for Joey to take on, and be there to sort of debrief after, whether we're a counselor or a family member or a friend to Joey. And some community resources that we highly rely on and refer people to, Transactive Gender Project out of Lewis and Clark. Jen Burleton is the executive director there and is just a force of nature. And she has support groups for both young people from ages 4 up until young adulthood, as well as caregivers. SMIRC, so the Sexual and Gender Minority Youth Resource Center, which is now part of New Avenues for Youth, and SMIRC East, which is on the east side of Portland. The Living Room in Clackamas County, Basic Rights Oregon, Fierce Families is a statewide resource. PFLAG is a national resource, and communities throughout the state have access to PFLAG chapters. I know for a fact that Portland PFLAG has been successful at moving their support groups virtually during the time of COVID. The Family Acceptance Project has some really great research and resources for building family resilience and acceptance so that we support our youth resilience and self-acceptance. Gender Spectrum also is an online community with some chat forums. They run a conference, and there's lots of resources available as well. And then the last two on here, Trevor Project and Trans Lifeline. These are dedicated hotlines for folks who are experiencing distress all the way up through feeling suicidal. Trans Lifeline has been created by and for trans folks, and all of the operators exist underneath the transgender umbrella. And then Trevor Project is they have a dedicated crisis line and text crisis number for youth under the age of 25 that might be experiencing distress. And then Trevor Space is kind of a offshoot of the Trevor Project, and it's an online community for LGBTQ plus youth under 25. So for folks who are a little more isolated or have a lot of social anxiety, and in-person groups aren't happening either right now because of our public health crisis, or that's just not accessible to someone, Trevor Space can be a great resource. And then when we think about medical care, as I mentioned, this is just a small piece of the puzzle, and pursuing medical care can be impacted, or the ability to pursue medical care can be impacted by those other factors in a young person's life. So, as I mentioned, part of my work is within our pediatric gender clinic through Dornbecker Children's Hospital. We have an interdisciplinary team, which means that patients and families have access to the endocrinologist or the hormone doctor, myself as social work, psychology, and nursing. We do not have a one-size-fits-all approach. So having a phone intake with me, coming to the first clinic visit, that doesn't sign anyone up on the train to transition bill. We really believe in giving folks information so that they can make the best decision for themselves, their family, their young person. And we individualize our care and individualize our follow-up schedule based on each patient and family need. Each patient's and family's need. We do have outreach clinics around the state as well, so it doesn't always require a trip up to Portland. And in fact, all of our clinics have been virtual since March, so we hope that that continues. There are psychology-only appointments available for evaluation for the purpose of diagnostic clarification and letters of support. And Dr. Moyer, who's our psychologist, can meet with folks for brief treatment. I hold social work only visits, which can be everything around name change navigation to insurance navigation and enrollment to preparation for surgery. Really, I often refer to myself as the cruise director. So if someone isn't sure, they can ask me, and if I'm not the right person, I'll find someone else. And then we have a fabulous team of nurses who can do injection training, so folks don't have to keep coming into clinic to get their injections. And our philosophy is to follow the gender-affirming approach, which first and foremost means we take this child's word at that moment in time. We appreciate that their identity may change over time, but we're really trying to be in the here and now, and we encourage families to do the same. We want to understand the motivations for someone pursuing a transition, and we also want to thoughtfully take that child's lead in exploring gender identity and thinking about what next steps might look like. And I sort of emphasize this idea of thoughtfully. So we're not handing hormones out on the street corner, despite what news outlets might suggest. We are taking in information about who this child is from the child themselves, really seeing them as an expert in their life, but recognizing the role of family and the information that they can add in. We then give our information back, and collectively with the family and with the mental health provider are thinking about what the next best step looks like. And then we also want to think about assisting that young person in navigating a wide repertoire of interests. I think sometimes what we see is when folks come out, regardless of their age, there's a tendency towards sort of stereotypical behavior of whatever identity feels affirming to them. And partially that's safety, but partially it's kind of what they're hearing in their immediate world and in the media. And so helping a young person understand that there can be diversity in how they experience their gender identity from the person next to them, and it doesn't make them any less trans. And the decision to recommend early gender transition should ultimately prioritize that child's well-being. And we often say that waiting is not a neutral option. So it's the balancing act of whether other people in the child's life are ready for them to kind of move forward to the next step in their transition, whether the child is developmentally ready to do so, with the recognition that pressing the pause button or putting additional questions or barriers in place may increase distress. And so it's a constant balancing act to decide kind of what is the right time and what is the right next step for an individual person. But what we know is that when gender affirming care is offered, it works. It has benefits. And this was a study that took data from the 2015 U.S. Trans Survey, which was a survey of adults, but asked those adults to look on their affirming care experience. And about 2.5% of the folks who responded to the survey had been able to access pubertal suppression or puberty blocking medications. And when they were able to access that medication, there was a lower risk of suicidal ideation for that person's entire lifetime. So it is a life-saving intervention. And when we're thinking about care planning for youth, there are different factors to take into consideration based on who's interacting with their world as stakeholders. So we want to think about insurance coverage and whether there are age restrictions on the plan related to particularly surgical care. Does this youth have access to transportation to get to clinic visits or injection appointments or post-op appointments? What is this young person's health literacy level, and what is their family's health literacy level, and what information do they need to be able to make an informed decision? We're also thinking about support systems and how that can look very traditional with a nuclear family and extended friends and et cetera, or whether we need to think more creatively about what this person's support system looks like. We're considering their other mental health experiences. So what does their baseline look like? How would moving forward with affirming their identity potentially free up energy for them to start addressing other aspects of their mental health experience? Where are they getting their information, and what are their future transition-related goals, and how do those align with timelines, times, etc.? So it can be a pretty complicated picture, and that's often where social work comes into play to help piece this all together. And if there are community mental health providers on the call here, brushing up on some of your own information and education can be helpful to walk families through the decision tree around this and considering all these factors. But when we're talking about medical care and talking about puberty suppression and puberty blockers, one of the main benefits is that it presses a pause button. It presses a pause button up at the brain, which is really where puberty starts. And it gives young people more time to explore their gender without fear of further physical development or changes. It might mean that they can begin to socially transition without the fear of their body continuing to change. And so there is a bit of a critical period here for these medications to be most effective in terms of being a pause button to prevent the secondary sex characteristics. But there can be an individual role for puberty blockers or suppression beyond that initial critical period. And so that's one of the conversations we often have, depending on the age of the young person. The other benefit is that these are reversible medications, so they can be stopped at any time, and the young person's puberty would pick up exactly where it left off. So they would catch up with their cisgender peers, and there wouldn't be any irreversible effects at that point. I often get the question of how long should someone stay on pubertal suppression, and the frustrating answer with much of this care is it depends and it's patient specific. But there are some considerations that the doctors will talk with folks about around protecting bone health and what it means to not have a sex hormone in the body for 4 or 5 years of time. And there sometimes is a benefit for continuing with suppression even after someone starts hormone therapy. And I will add that just because someone goes on to pubertal suppression does not mean that they automatically are signing up for hormone therapy or will choose to do that to affirm their gender. But the main benefits of staying on pubertal suppression once hormone therapy gets started is to suppress periods or cycles until testosterone would have that same effect, and to prevent any further chest development because testosterone is not going to prevent that. For youth who were born with testicles, pubertal suppression is the most effective way to suppress testosterone completely. There are other medications that sort of block the body from taking in the testosterone, but this is the most effective if a young person can tolerate it and wants to be on it. And so when we talk about hormones, what we want to be thinking about is whether someone is developmentally ready to make this decision. And it's not just an age. There is no magic age. Previous guidelines used to suggest that it was 16, but that was based on really the care that was being provided in the Netherlands, and the age of medical consent in the Netherlands was 16, so it just became sort of this arbitrary thing that got released around the world. And the other sort of potentially interesting thing, I think it's interesting because I geek out about this stuff, but the Netherlands is a country with socialized medicine, so youth who come out earlier than 16 were able to access pubertal suppression, and so waiting until later into the teen years wasn't as distressing. But that said, I sort of went on a squirrel brain tangent there, so I apologize. I'll rein it back in. There is no hard and fast age cutoff. So the Endocrine Society suggests 16, but indicates that there are compelling reasons to start hormones prior to 16. And that can be, the length of time that someone has been in puberty, where their peer group is at, because if we wait to start a transgender girl on estrogen until she's 16, most of her cisgender peers will have completed puberty by the time they're 13, 14. And so it's just another potential social risk factor to make someone wait that long, in addition to the internal distress that they might be feeling related to their identity, body, and how the world is seeing them. So those are things to consider. We also want to make sure that both the youth and their family understand what is reversible, what is not reversible, and that there's an ability to provide informed consent, which means understanding all of the risks and benefits and saying, yes, I'm okay with that. So as I mentioned, other considerations for starting younger than 16 is the potential risk for anxiety and depression worsening. And if someone has already been on pubertal suppression for 2 or 3 years, they're not getting the protection of the puberty hormones for their bones. And so starting hormone therapy is going to be a protective factor against osteoporosis later down the road. The considerations for waiting would be whether a young person is uncertain about how they feel about maintaining their fertility potential, particularly folks who are assigned male at birth and are considering going on estrogen. And then non-binary youth in particular sometimes need a little bit more support in kind of figuring out which puberty they want to go through, because neither puberty really feels completely in alignment with who they are. Or they might want some physical changes, but not all of them. And so it can sometimes be a frustrating and difficult conversation for that young person to think about and have. And that's where the adults in a young person's life can help facilitate that conversation, can open the door to make sure that they feel like they can express where they're nervous, where they're ambivalent, without an adult being like, oh no, you're not sure, we got to pump the brakes. So keeping that in mind. And when we're talking about fertility and medical treatment, the puberty blockers, they're officially called GnRH agonists, have no reduction or impact in fertility. And these studies come from children who were given pubertal suppression because they started puberty too early. There are not many longitudinal studies at this point for gender diverse youth, largely because there isn't a large enough cohort that has been able to access this medication for a period of time and then age into adulthood. But what we do know is that there's no reduction in fertility potential from those early puberty studies. For estrogen, what we do know is that it can be damaging to sperm. And so our best counseling, our best advice for folks who are assigned male at birth is that if they are curious about their fertility potential, that is best done, or a conversation best had before starting estrogen. The difficult piece here is that someone has to go through enough puberty in order for there to be mature enough sperm to be able to submit a sample for preservation. And with testosterone, there's caution that it can impact the ovaries, but there's emerging research that is showing that testosterone is not as damaging to ovaries and eggs as once thought, and that if someone comes off of testosterone and can resume their cycle, then they are likely to be able to get pregnant if they wish to carry a pregnancy, or utilize their eggs to get someone else pregnant. And we also always caution that testosterone is not a reliable form of contraception. Even if someone is not having cycles, there is still a possibility that they could get pregnant, and then that would be dangerous to the developing fetus, and they would have to come off of testosterone at that point. There are fertility videos on our website. So it's ohsu.edu/transgender health. And that information will be at the end of this presentation. But they're really informative videos for both folks who were assigned male at birth and folks who were assigned female at birth. OHSU also, through their fertility clinic, hosts baby talk events, which are kind of open houses where folks can have a quick 15-minute consultation with one of the reproductive endocrinologists free of charge, and then decide if they want to have continued conversations. So that's also a resource for you. When we're thinking about youth and surgery, Again, there's no magical age. We're thinking about stages of development, maturity, support system, and we really want to think about individualized care. And some of the things that help youth make a decision and some of the things that help the providers and support systems make a decision are thinking about who are the natural supports in this person's life, what is this person's expectations for surgery, and what are the person's expectations for surgery, and how do those align with what surgery can deliver. Answering the question of why now. So, this might be another situation where waiting is not a neutral option, and so pursuing surgery will result in the potential reduction of anxiety and depression, and so we want to see that. And we're also thinking about, the benefits of someone having surgery while they're still connected to their natural support system rather than being away at college or in the military or at some other post-secondary training program where they're having to time it around breaks and maybe recovery is rushed and some of the natural supports have gone away. Not to mention, the psychological benefits of being able to launch into adulthood more affirmed in their identity and body. So that's something that we're considering. I also want to think about custody and consent issues. So the age of medical consent in Oregon is 15, which technically means a 15-year-old could consent to surgery on their own. But sometimes being involved with DHS or Oregon Youth Authority complicates who can provide consent for particular treatment. And then we also want to think about insurance and whether there are limitations related to someone's age, and if the plan says that someone has to be 18 before seeking surgery related to gender transition, that's usually a pretty hard stop that we're not able to appeal. We see that when we look at sort of the guiding bodies that are out there, WPATH, which is the World Professional Association for Transgender Health, is silent on the suggested age of surgical care. Oregon Health Plan is also silent on the age, but as I mentioned, commercial plans may have age restrictions on there. So that brings me to our take-home messages. And first and foremost, we want you to know that affirming care is holistic care. So it's taking into consideration not just the medical care that someone is seeking, but what has their social transition been like? What does their social world look like? And where are the potentials for intervention, either from our team or community partners or family members, to help improve the outcomes for that individual person and others in the community. We also know that gender identity is solidified by age 5, regardless of someone's ability to explore or express it. And so if we are parents or if we are considering becoming parents, how do we create an environment where there is freedom for someone to explore and express their gender identity at that young age? Having one supportive adult in a young gender diverse person's life significantly improves their mental health outcomes, to reducing them to the levels of their cisgender peers, or reducing rates of depression and anxiety to that of cisgender peers. And when we're supporting social transition, so using someone's chosen name, pronoun across their social world, this can be a life-changing intervention by reducing suicidal ideation and behavior. Hormones, pubertal suppression, and surgeries are important. They're not the only interventions. Some of the most effective interventions are around supporting a social transition and intervening with other aspects of a youth's life so that there's more support wrapped around them. And being in a gender diverse young person's life is an honor, first and foremost. When a young person is telling you about their gender identity, they're letting you into their world. And that's something that I do not take lightly. And it also means that I can't leave my responsibilities in the clinic room. I have to be an advocate. The world isn't going to change and be more open and expansive for our gender diverse youth unless we help it along. And I think we're seeing that now more than ever. Being an advocate requires us to have courageous conversations. It might make us incredibly uncomfortable to do this, but if we can wrap more support around our young people and change one person's heart and mind, then that person potentially can change other people's hearts and minds, and we start helping that world along a little bit. So we need to be willing to show up and have these conversations with extended family, with faith communities, and with school systems, even if it means that we might be experiencing discomfort or even experience rejection from those entities. But we're doing that alongside of our young people who are needing us to be advocates and who shouldn't be the only ones having to make this lift. And when we're thinking about being an advocate or an ally, it's important to come to agreements with the young person in question to understand what they need and how they want us to act on their behalf when they're in the room, when they're not in the room, etc. And so that's, if you take away one thing today, it's whatever your role is, whether it is parent, counselor, faith leader, that is not your singular identity when it comes to working with gender diverse youth. We have to be able to step outside of what we think our roles are and stretch a little to make this a more open, affirming, and expansive world for our young people. And that's our contact info. So we have a website, as I mentioned. We do have an email address. I will tell you, I am the only one that manages our email. And so the easiest thing is to actually fill out a service request form on our website, where you can select the topic information that you're interested in or that your young person is interested in. And then there's a free text space for you to be able to ask specific questions. And so that helps kind of consolidate the amount of emails back and forth. But also it gives us the ability to track how much traffic is coming in and hopefully use that data to get more staff, because we want to be able to be more responsive more quickly, and really be able to support people to the best of our abilities. So, all right, I think that concludes my slideshow here. I'll leave this slide up here for folks to write down the information, and then I think Amy's gonna jump back in and ask me some questions.
Thank you so much, Jess, for that wonderful presentation. I have been collecting some questions that have come in through the chat, some of which I've attempted to answer, but many of which I think warrant further discussion. So I'm going to go ahead and start going down the list of some of the questions, hoping that you can offer some additional comments and reflections. So
Sure.
There were definitely some questions coming in thinking more broadly about the lifespan, questions particularly oriented to younger children in the preschool range and understanding a bit about what gender might look like at that stage of child development, how to create safe space for gender exploration. And then on the other end of the youth spectrum, more questions around some things that we should be thinking about or considering for young adults. So let's start with the younger kids, and then we can talk about the young adults, and then we'll pause for the next question. Thank you.
Great. Yeah, thanks, Amy, and thanks for those questions. When we're talking about preschool age kids, so the 3, 4, 5 age range, you know, that may be the first period of time where we're seeing gender expansiveness emerge, either in language or in play. It also means that we need to be curious and not sort of jump on the fear wagon necessarily and say like, okay, you know, my child who was assigned male at birth is only wanting to play with girls and is interested in princesses, etc. So this definitely means that they're going to be transgender, and so you know, now I have to be fearful about what that means. That very well may be that child's journey, but trying to stay present and think about that gender affirming approach and say like, okay, at this moment in time, this is what my child is interested in, and maybe they don't have language yet to describe who they are, but I'm going to continue to offer a wide range of activities, interests, clothes, etc., and see what my child gravitates towards. If they do start, excuse me, if they do start using language like "I am a girl," "I am a boy," "I hate my penis," "God made a mistake," then we want to pay attention to that level of distress and start having age-appropriate conversations and providing reassurance around like, no matter who you grow up to be, we're going to support you, we're going to love you. You know, I know not every family, unfortunately, is giving that message, but if you are a parent, you know, thinking about using that language, bringing in, you know, I say this for any kid, regardless of whether they're expressing gender diversity, have a wide variety of books with a wide variety of characters available so that folks can see, young people can see the different gender possibilities that are out there. And we do have a resource list that has some good books on there broken down by age category. So those are the things that I tend to think about. Obviously, at 3, 4, 5, there's not a need for any medical intervention, but our youngest patient right now is 3 because the family said, you know what, we want to know what to prepare for. So they came in, they got the information. We'll check in with them, you know, once a year until puberty comes a little bit closer. So that's always an option as well. And then for young adults, we want to be thinking about a variety of things. So sometimes there is the sort of passive support / passive resistance from families who say, you know, my obligation is to you until you turn 18, so I will kind of tolerate this gender diversity thing, but if you're going to pursue additional transition, you know, you're kind of on your own at 18. And so thinking about if you are a service provider working with that young person, where else this person can get support. There's also the element later in young adulthood of aging out of youth services. So I mentioned SMERC as one of the options. I mentioned Trevor Project, and those have age caps. So what is the transition to adult services, to adult support groups? And is there going to be kind of a generational gap there? So learning as a service provider about the resources that are out there, not just for the age that you work with, but sort of the next developmental age. There's also the potential that young adults are moving away from Oregon or wherever they were born and away from their natural supports. So whether you're a family member or a provider on this call here, thinking about reputable places to research care providers wherever that young person will be ending up, so that there's no lapse in care. I also think about insurance navigation, and for young adults who have previously been covered under a parent's plan, and that parent is either not supportive or the insurance plan itself has an exclusion on it related to care for gender dysphoria, then at 19, the young adult can apply for OHP on their own. And in some cases, at 18, a young adult can apply for OHP if their legal guardian agrees not to claim them on taxes. I was just going to say, please don't ask me a ton of insurance questions tonight, but if you do have questions about that for yourself, for your family member, for someone else, then we can talk about what that looks like later. But I recognize I just opened Pandora's insurance box, so apologies for that. Yeah, I think I'll leave it at that for young adults. Amy, I know that this is a group that you've worked a lot with as well. So if you have anything to add as my better half, feel free.
We keep calling each other the better half.
Yeah.
I think with the young adult population, I think we should not forget the adults that are still in their lives to support them and keeping them close in enough to stay engaged as supports and allies, while also appreciating a level of autonomy and desire for independence and privacy for the young adult.
Thank you.
Yes. I am still answering questions in the chat that maybe don't need larger discussion, so I'm going to move into the other questions that have collected over time. Let's see. A really great question came in about, will a child always bring up their gender on their own, even in a supportive environment, or should parents ask their child about their gender identity at a certain age?
That is a great question. I think laying the groundwork with those statements of support early on in life and doing so repeatedly is going to invite the conversation. But if you're recognizing that a young person in your life seems to be experiencing distress, and there is that close relationship, then I think it's appropriate to say, you know, hey, I've noticed, you know, something's going on with you, something's shifted. I've noticed that the way you're dressing has changed a bit. Is there anything that you want to talk about? And the kid might say no, depending on their age, because sometimes that's just developmentally appropriate. And then you can potentially follow that up with, you know, are you thinking about your gender identity? If you are, know that we support you, and let us know what you need as you move forward. And the young person might not take up that invitation right then, because the other thing to just remember is that this is a process for everyone. And it can take a while before a young person lands in the space of, I feel ready to acknowledge this for myself, and I feel ready to start talking to other people about it. And then, you know, the rest of the social world around this person also is shifting and changing with them. So hopefully that answers your question.
Thank you, Jess. We did have some questions coming in from an attendee, questions related to detransition and how is detransition care delivered, and what does that mean in the long term for young people who might start care and have regret or change their mind later?
Sure. So within our pediatric clinic, frankly, we normalize the conversation about people changing their mind. And we don't do that in sort of a flip way, but we, as part of informed consent, offer that up. And someone changing their mind can look like a variety of different things, but what we want to know, or what we want patients and families to know, is that this is a place where you can have the conversation and ask the question. So from the get-go, we're talking about the things that are reversible versus irreversible. And then if someone were to move into a space where they wanted to, discontinue testosterone because it didn't align with their gender identity, then we would talk about how to do that in a safe way, while also sort of reminding that person, okay, well, these are the changes that have taken place that are going to stay. These are the things that might shift back to the way that they were. Your cycles are likely to come, things of that nature. And we just try to sort of stay calm about the whole thing, because I think the topic of detransition can be very polarizing, and also detransition in itself is a bit of a misleading concept because, as I mentioned early on, there are many reasons why people might stop a medical transition or change course in some way. And I know I mentioned the sort of testosterone example, but there are lots of reasons why people would stop testosterone. Maybe they want to carry a pregnancy. Maybe they've experienced all the physical changes that they want, and they're comfortable where they're at, and so they don't want to take that medication anymore. Maybe they've developed injection fatigue and are satisfied with the level of change that they're at, etc. However, when it comes to the point where someone may have had their ovaries or testicles removed and are on a particular hormone, then there's going to be counseling about what it would mean to stop that hormone therapy altogether, and how that would impact their body. So, Amy, do you have anything you want to add around the detransition stuff?
Yes, I mean, this is something that as a program we take very seriously. When anyone approaches us and says that they did not have the outcome that they expected, they might have regret, or they are having a continuous change in gender identity. These are things that we do want to hear about, and we do want to be responsive towards for anyone who access care with us. We are finding that there's an exceedingly low incidence of that, and whether that's because it's a low incidence or because someone isn't reporting that to us, I suppose is yet to be determined over the long run. The literature suggests a very low incidence of regret and detransition. But this is something that we do want to hear about from patients should this emerge, and it's also part of why we have amplified our behavioral health and psychology services as a means of prevention, because that is not an outcome that we would want to see for anyone, and something we do want to hear about. I'm going to shift over to another question that came in, which I think you touched on, but maybe you want to elucidate a little bit more. The question is largely around consenting and how we address. We talked about having a patient and family centered approach, but questions about young people who may be in DHS child welfare custody or youth authority, foster care, or young people whose parents are not in agreement and very opposed either with each other or with the young person. Do you want to get into a little bit around decisions and consenting? Sure. And some of what guides that?
Sure. So, as I mentioned, the age of medical consent in Oregon is 15. So sometimes with DHS, what we see is the DHS worker will say, hey, this person's 15, they can consent on their own, sort of, we support them, but we're not going to sign any official documentation. Other times there are more restrictions in a particular case, particularly if it's a reunification case. In that case, DHS might be the party that has to give consent, but they might seek agreement from the parent or parents that they are trying to unify the child with before doing so. In some cases, the biological or birth parents are not on board, and so then it requires going to a judge to get a court order for that. And obviously that's a time-consuming process and stressful for the young person. So I think in those cases, making sure that the messaging is like, we're continuing to work hard for you. We're going to try everything we can to support you. Let's think about other ways that we can affirm your identity until the medical care is consented for, things like that. Our program standpoint across the board is to frankly work our tails off to try to get one supportive adult, and hopefully that adult is someone who can provide consent or co-consent. We want to get that person on board. And so it starts at intake with me, where I'm providing education. I'm trying to find some middle ground. I'm trying to reframe what the communication has been like so far. I'm trying to speak to a parent's or caregiver's fears and concerns. And then in some cases, Dr. Moyer, Danielle, our psychologist, will meet with families in between my intake and the multidisciplinary visit to try to do some work there, or we connect that family with a community provider who can also do that work. In some cases where it becomes clear that an adult supporter is not going to be on board and the level of distress for the young person is significant, then we have moved forward with prescribing with that 15-plus-year-old providing consent on their own behalf. Before we do that, we are having a very, very careful conversation about safety, housing, if they're utilizing someone's a parent's insurance and that parent is not on board, how are they going to cover copays, coinsurance, deductibles, prescription costs, things like that. And then who can they think of as support people in their life in the case that that things get uglier than anyone would hope or anticipate. So hopefully that answers the question. But to summarize, DHS can be complicated depending on the individual case details and what the plans are for custodianship. Our program model is to work to have family members on board while also recognizing the distress that waiting can cause for a young person. And in rare situations where we feel like every avenue has been explored, we will move forward with prescribing with careful conversations.
Thank you, Jess. There was a question in regards to, a couple questions in regards to resources. One that came in about what resources could we share to help people navigate conversations with extended family or being an advocate. I commented that PFLAG and the Transactive Gender Project are really great resources for that. If you have more to add to that, and if you could also tie in for folks that are in more rural areas who don't have immediate access, recommendations that you have for that.
Sure. Gender Spectrum and Family Acceptance Project have some pretty great guides. I always joke that I feel like I need to write to these authors and ask them for royalties, but the authors of The Transgender Child and The Transgender Teen, they have written these books. Stephanie Brill and I think the other author's last name is Pepper, where they kind of talk about a child's and a teen's social world and how to navigate those conversations. So those would be other resources. And for more rural communities, I think one of the potential, if there can be a benefit of a public health crisis, I hesitate to even label it that, but because so many things have transitioned to virtual worlds, it means that communities who previously didn't have access to those resources are able to do so digitally, of course, that they have the ability to connect and whatnot. So Transactive Gender Project, I know we've mentioned that many times over, but they are a statewide and a nationwide resource. Anyone can join their support groups. We recognize that sometimes there can be a difference in experience between folks who exist in more urban areas and rural families, but if there are more folks coming from rural areas, then the conversation is going to kind of open up there. In Coos Bay, there's the Coos Youth Drop-In, where they host an LGBTQ teen group. Salem has Rainbow Youth. Eugene has Transponder, which is a larger resource body. They help connect people. We are exploring, there's a youth era drop-in down in Medford, and we are currently having conversations with them to see what support we can provide to them so that they can support the youth in that area from a gender-affirming standpoint. And then I would think about the larger online communities. So there are some closed Facebook groups for caregivers and parents. Mama Dragons is a group of Latter-day Saints moms who have trans kids. If you're looking for faith community specific, and then Trevor Space for young people, and I can probably come up with a bunch more if I had the Google machine going. So if folks are from rural communities and looking for more resources, please fill out one of the service requests on our website, and we can have further conversations.
Thank you, Jess.
Sorry. I knew I'd think of another one. Down in the Bend area, Human Dignity Coalition, as well as many of the primary care doctors and mental health providers have done a ton of work to kind of build capacity and affirmation in the area. So reach out to them if you're down that way.
Thank you, Jess. There's a question in terms of advocacy, are there certain policies that we could be helping to work towards? And I answered that general advocacy at schools or within athletic clubs, faith communities, health plans, medical offices, etc. Any place that we think our young people are accessing is just to make sure that they're welcoming and inclusive by asking them about their policies of inclusion and patients' rights if they're an environment where it's a patient relationship. Jess, is there anything else that you would want to add in that regard to policies or advocacy?
Sure. I would suggest asking about non-discrimination policies and whether they include language around gender identity and expression, and then how those are upheld or encouraged or enforced. If you're thinking about advocacy within, an employment setting, or, really any setting, but thinking about gender-neutral bathroom options, comprehensive healthcare coverage with the insurance, being able to have someone's affirmed name in an official email address or in a medical chart, basically any outward facing communication, if that can be utilizing someone's affirmed or chosen name and pronoun, that is the best policy in practice. So hopefully that gives folks some ideas. And I think that I'm getting a signal that there are no more questions. So I appreciate that you all spent this 90 minutes with us tonight and your commitment to protecting trans kids, and feel free to be in touch and also reach out to all the awesome organizations that we listed off as well. It takes our whole community here, so thank you for being here and for helping out our kids.
Thank you, Jess, for this amazing presentation. As a reminder, this presentation has been recorded, and you can contact Alder Commons to get a link to this recording or any other feedback you'd like to give to them. As the hosts and conveners of this event, thank you so much for inviting us. Nice to see all your faces and be in dialogue with you this evening. Have a good night.
Thank you, Amy. Thank you, Jess, so much.